It is with great delight that I introduce Dr. Arun Sanyal. He is someone who probably knows more than anything about most aspects of bile acid biology and its intersection with adult medicine and even pediatric medicine. He is a professor of medicine in the gastroenterology division at Virginia Commonwealth University in Richmond, Virginia. Professor Sanyal is going to give the following talk, potential therapeutic roles for IBAT inhibitors in metabolic liver disease, bile acid biology, and NASH.
Good evening, everyone, and it's a pleasure for me to talk to you today about the potential therapeutic roles for IBAT inhibitors in the context of NASH and other metabolic liver disease. Just having a little technical difficulty here. Trying to get the slides to move. Do I have control? Yeah, there you go. Here are my disclosures. So after this presentation, you should be able to describe the basic mechanisms involved in the development and progression of NASH, describe the changes in bile acids in NASH, and the mechanisms by which bile acids can affect pathways that are relevant for the development of NASH. So let's start with a stage-setting question. Which of the following NASH-related pathways are modulated by bile acids? Please select all that apply. Activation of de novo lipogenesis, impaired intestinal barrier function, incretin and intestinal GLP-1 release, oncogenesis, and dyslipidemia. Please vote now. So it's clear everybody agreed on this, most people agreed on dyslipidemia, followed by de novo lipogenesis and GLP-1s. So let's see what the data actually show. So we start with the current view of how NASH develops. And basically, one may think about it in a four-step process. So the pathophysiology of NASH is driven by the delivery of excess metabolic substrate to the liver in the context of a systemic milieu of obesity, insulin resistance, and increased pro-inflammatory cytokines and gut-derived factors from the microbiome, etc. So when these excess metabolic substrates come into the liver, particularly in the form of free fatty acids and glucose, they turn on the metabolic engine within the hepatocytes and put it in overdrive, which in turn results in cell stress of various forms, such as oxidative stress, unfolded protein response, mitochondrial stress, which, if severe enough, will trigger cell death. At the same time, these processes trigger inflammatory responses. And the innate immune system is an important bridge between this cell stress and cell injury to the activation of inflammatory pathways, with a key role for the inflammasome, extrahepatic signals for the innate immune system from the gut microbiome activating toll-like receptors, and then secondary activation of the adaptive immune system, inflammatory cytokines. Then all of these converge on the hepatic stellate cells to activate them and trigger a fibrogenic remodeling response that drives cirrhosis. So what does any of this have to do with bile acids? To understand this, we need to go back to basics and start from scratch by walking step by step from how bile acids are handled by the liver to how they function and how they could impact the development of NASH. So bile acids are derived from cholesterol, and it is the principal mechanism by which the human being can get rid of extra cholesterol. And these bile acids that are produced in the liver are primary bile acids, as Paul mentioned. These get conjugated, secreted into bile, come out in the intestine, and in the intestine, a large proportion of this is retaken up via ileal receptors and in the ileum, it also triggers release of a compound called FGF19, which feeds back on the hepatic bile acid synthetic machinery. A small amount of bile acids actually escape this path and end up in the colon, where they can activate colonocytes and trigger release of GLP-1, etc. Now, in the colon, that's where the bulk of the microbiome exists. So these secondary bile acids can also be altered by the microbiome. Also, the primary bile acids in the microbiome get altered and converted into secondary bile acids in the colon. So with this background, we looked at how this profile of bile acids, the primary bile acids and the secondary bile acids, which are derived from microbial alteration of the primary bile acids in the colon, change as we develop NASH. And this is shown as a heat map with the different bile acid species on the left. But strikingly, what is important to remember is that as you go from control to fatty liver to NASH, while the total secondary bile acids as a function of total bile acids decrease, the proportion of a specific secondary bile acid, deoxycholic acid, which is derived from dehydroxylation of taurocholic acid, that actually is increased. This is, of course, the relevance of this will become clear as we move along. So to take a deeper dive, we looked at different species of bile acids at different points in the course of the disease. And this is now looking at the fecal bile acid profile. So this is actually being presented this year at AASLD by Mark Mutaya, who is, I think the poster number is 351. So if you look on the right, what you see over here is that in green, this is a radar plot. It shows sort of the bile acid profile of specific bile acids in the stool in the normal individuals. Now, when you develop a fatty liver, you start seeing an increase, modest increase in deoxycholic acid. But then as you go from fatty liver to NASH, there's a fairly substantial increase in the various both deoxy as well as chenodeoxy derivatives over here. Now, as the NASH progresses into advanced fibrosis, when you compare patients with advanced fibrosis with early fibrosis, then some of these things decrease. And what you're seeing over here are deoxycholate, again, findings over here, and some secondary products derived from deoxycholate, such as 12-dehydrocolate, etc., which are increased. Now, what is also interesting is that the taurodeoxycholate decreases. Now, as you become more obese, the gut microbiome changes, and actually a lot of the taurine gets used up for sulfation reaction. So this is most likely a function of decreased taurine availability in the stool. But this is giving us a clear signature that at different points in the course of the disease, the bile acid profiles change, and a clear signature for deoxycholic acid and its derived bile acids in that pathway begins to emerge. So to look at this further, we looked at the different bile acid metabolizing genes within the gut microbiome, starting with bile acid hydrolase and a variety of number of genes within the bile acid inducible operon, the bi-operon that is involved. And there are a number of comparisons shown on this slide, starting from the left with control versus fatty liver disease, everybody, then comparing fatty liver versus NASH, then high activity versus low activity, and then with fibrosis stage 2, which is clinically significant fibrosis, versus those with more advanced fibrosis. And what you see here is that some of the key enzymes involved in the metabolism of over here, and I'll focus you over here on BIE and BICD, which are significantly increased and are involved in the production of deoxycholate. So we're beginning to nail down in a more granular way the biological basis for why the deoxycholic acid actually increases as you get increasing fibrosis. And then if you look at the differentially expressed taxa with progressive disease, we can actually begin to connect the dots between these changes in functionality of the microbiome to the structure of the microbiome. So here shown in a heat map again, with red being increased and blue being decreased, what you're seeing is as you go from comparing all patients with fatty liver disease to control, to comparing fatty liver versus NASH, high NAS versus low NAS, clinically significant fibrosis that's stage 2 or higher versus lower stages and advanced, you can start beginning to see what microbiota are changing. And what is very interesting is that the bile acids themselves have an antibiotic effect on the microbiome, and you're seeing a shrinkage in some of these bacterial taxa that are sensitive to the antibiotic functions of deoxycholic acid. But there are other bacteria that love deoxycholic acid, love bile acids. They grow and they're bilophilic. And one very important one is bilophila. And what you see is that the bilophila actually starts increasing. And bilophila has been particularly connected with increased inflammatory activity in inflammatory bowel disease and other bacterial illnesses. So these changes in bile acids and how they may contribute to different elements of NASH start becoming clearer from this. Now, so far we just talked about the bile acid machinery and how it changes at different points in the course of the disease. What is the functional impact of that? Well, we already know that bile acids come in and undergo this enterohepatic circulation, and they feed back through this both in the intestine and in the liver. The circulation feeds back through the FXR bile acid receptor. Bile acids also affect other receptors. So let's first take a look at the FXR pathway. So the FXR pathway itself not only is involved in regulating the movement of cholesterol into bile acid and shut it down, and then get rid bile acids out of the hepatocyte, so it gets rid of bile acids. But it also is an important metabolic signaling molecule. Every time you have enterohepatic circulation, these bile acids are telling the cells in the body nutrition is coming. So it allows the cells to reset its nutritional machinery. So the FXR actually has significant effects on glucose metabolism. It modulates insulin signaling, gluconeogenesis, glycogenesis. It has effects obviously of shutting down the bile acid synthesis, increasing bile acid export, but it also has effects on triglyceride synthesis and decreases VLDL. So all of these potentially would be expected to improve. Now, but the FGF, when the bile acids come out in the intestine, they activate through the intestinal epithelia release of FGF19, which then feeds back onto FXR, but also through FGF receptor 4. It has additional effects. So all of these then potentially lead to defatting of the liver, and which would be considered to be beneficial. And as all of you are aware, both FGF19 and FXR agonists are being studied in clinical trials, and obeticholic acid is pretty far along in clinical development. What about other bile acid receptors? So some years ago, we showed that INT-777, which is a TGR5 ligand, actually modulates weight gain in DB/DB mice after followed over a period of 7 weeks. And we know that some of this could be related to release of GLP-1, but there are other effects of TGR5. So under normal circumstances, we have shown previously that TGR5 actually plays an important role in pancreatic islet function. So under normal circumstances, first we showed that the beta cells in the islet express TGR5, and that bile acids could activate through TGR5 release of insulin, and we worked out the signaling pathway involved. Subsequently, we looked at the alpha cells and found that in the normal circumstances, the bile acids via this basically cleaves proglucagon to release glucagon and increases glucagon release as well. Now, when you become diabetic, when you are under insulin resistant and your cells are under, the islet cells are under lipotoxic stress, this becomes modified. Now, it is very interesting that glucagon and GLP-1 have a common parent. And based on alternate splicing and cleavage, you can get glucagon or you can get GLP-1 from proglucagon. And so PC2 activation releases glucagon, PC1 releases GLP-1. Under hyperglycemic state, in diabetic state, you actually release through activate PC1, so you actually release GLP-1, which also further pushes the beta cells to make and release as much insulin as possible, an adaptive mechanism. So bile acids have multifaceted effects working through FXR, through TGR5, through the microbiome, through all these things that affect both diabetes and fatty liver disease. Another part of the story comes from this very interesting study from Japan, where they showed that the secondary bile acids, particularly again deoxycholic acid, can produce DNA damage and induce senescence, which is an important pathway that has been linked to the development of hepatocellular carcinoma. And this has now been confirmed by others as well. So one link from how you get from NASH and maybe even hepatocellular carcinoma in the absence of cirrhosis could be actually an increase in deoxycholic acid. This is something that needs to be confirmed, and this is something that is currently being investigated. Now, bile acids are derived from cholesterol, and this is a very good study for those who are interested to look at flux studies showing that you actually reduce the cholesterol coming out of the liver into the VLDL and eventually into the LDL. And so it does actually reduce LDL cholesterol. In animal models of fatty liver disease, this is data from Saul, our chairman here, showing that under high-fat diet conditions in preclinical models, the use of an IBAT inhibitor actually defats the liver, improves the NAFLD activity score, and actually reduces hypertriglyceridemia as well. Unfortunately, the study we have to date, this is Phil Newsom's paper in JHEP earlier this year, the histological improvement, which is 2-point reduction in NAS without worsening fibrosis, this endpoint was not met with volixibat, which is one of the IBAT inhibitors out there. They did, however, see a decrease in LDL cholesterol and total cholesterol, and there was target engagement because C4, which is a marker of bile acid synthesis, was actually impacted. So in summary, the expected impact of IBAT inhibitors on bile acid metabolism and NASH biology are: 1, the movement of hepatic cholesterol into bile acid pool and reduction in LDL cholesterol, which, because there's increased cardiac risk in patients with NASH, this is going to be important. Increased fecal bile acid loss and decreased availability of secondary bile acid exposure to the liver with potentially reduced oncogenesis. That, of course, has to be proven. Benefits could be further extended by targeting specific deoxycholate synthesizing bacteria, knowing that deoxycholic acid particularly increases with disease progression. Thank you.